Welcome. My name is Kai Karas, and I'm a postdoctoral researcher at the Karl Leuven in Belgium. Today, I would like to speak a little bit about the specific social challenges that the COVID-19 pandemic has posed specifically for people with chronic pain. And my talk is entitled The Social Threats of COVID-19 for People with Chronic Pain. I would also like to thank IASP for the invitation for this talk. To start, I would like to go back a little bit to before the pandemic, where I did, with several others, a little bit of work in the area of social threat and pain. The rationale for this is that pain is best be understood from a biopsychosocial model. However, we still traditionally think of pain mainly as a threat to bodily integrity and to the body. What we did is we tried to reframe this a little bit and pay some attention to pain as a threat to our social self. What we did then is to outline the different ways in which the research has shown that pain is associated with social threats. And we came to the conclusion that pain, next to being a threat to the bodily integrity, is also a threat to the social self in several ways. The specific ways that we identified, we organized among several fundamental human social needs. And there are several needs that people have. One is the need for bodily integrity, but there's also several social needs because humans are social animals. The first one is a need for autonomy. This doesn't sound necessarily social to begin with, but let me explain what I mean by that. People usually have the need to be in control of their lives, to not have to rely on others, and to be independent to some extent. Now, pain does challenge this need because it often shifts the agency from the person with pain to others. What I mean by that is that people who are in pain usually have to depend on other people around them, for instance, their partners, families, or especially healthcare professionals. This might be a dependence in terms of explanation, asking for help, asking for explanation about the condition, but also, for instance, in the case of healthcare professionals, about treatment and support. With regard to family and partners, this might also be practical help, for instance. This feeling is often associated with a feeling of being a burden, a feeling of helplessness, a feeling of having to depend on others against your own will. So pain, especially chronic pain, definitely challenges this need for autonomy in very relevant ways. The second one, and there's a lot of research about this, is the need to belong. People like to belong to social networks, like to be embedded in groups. And we know that chronic pain especially challenges this need. And this is because it places people with pain on the outside. People with chronic pain, especially if there's no biomedical explanation for the pain, are often excluded. They are less liked, their experience is less warm, and they're not taken as seriously. We know that people with chronic pain have smaller social network sizes and feel often isolated from their peers because, for instance, in a very practical sense, they're not able to engage in as many social activities because of their pain. So loneliness and social exclusion are very common experiences for people with pain. Lastly, there's a need for justice. People like to live in a world that is just, that is fair, where people get what they deserve. And of course, again, especially chronic pain challenges this need because it often is associated with perceived and also actual experiences and injustices. We know that there's large discrepancies for people with pain management based on, for instance, marginalized conditions. We also know that people with pain frequently perceive injustices. That can, for instance, be that they feel that their pain is not just, that they don't deserve it, that they're too young, for instance, to perceive the pain that they do, or in extreme cases, their pain might be the actual result of someone else's fault or negligence, like in the case of a car crash. In that case, perceptions of injustice are often associated with anger, feelings of hostility, and they often have as a consequence that pain is experienced as worse and disability is increased. Taken together, we reasoned that pain threatens several fundamental social needs. So it's not only a threat to bodily integrity, but it is also a threat to the social self. This graph is taken from the paper itself. I tried to summarize here how pain impacts upon these different social needs. The need to belong, the need for autonomy, and the need for justice, and several areas of research that have shown this relationship. What I would also like to highlight is that there's different levels that this relationship can be investigated. One is the individual level, which has received a lot of attention. The second one, of course, is interpersonal context, which is between different agents. but you can also go to a third level, which is the social cultural level. For instance, looking at how our societal idea about pain, for instance, that pain should be short-lived, should be fixable, how that impacts upon how people treat people with chronic pain, which often conflicts with these societal norms about pain. What I would also like to highlight is that there's a bidirectional relationship. And that is really important to realize. And that's also why it's important in the context of the current talk. The relationship between social threats and pain is bidirectional. And what I mean by that is that social threats can be consequences of pain. And there's a lot of research showing that. It's the social cost of chronic pain, especially, but there can also be antecedents. We know, for instance, that the feeling of social exclusion actually impacts upon the experience of pain in a detrimental way. We also know that early interpersonal experiences of trauma can increase the risk for the development of chronic pain. So really how this should be viewed is in terms of a cycle rather than a one-directional arrow, with social threat and pain being in a dynamic relationship with one another. And this is very important, both for prevention, but also for the treatment of chronic pain. Now, recently, what happened is that the COVID-19 pandemic affected the whole world. And I will term this pain in isolation because what it really did is it shifted our complete social fabric. The COVID-19 pandemic has led to unprecedented changes in our social fabric, mainly by impacting certain rules that had especially consequences for our social gatherings, for instance, social distancing rules. What we then wondered, especially based on the research that has been done previously, is the question whether these social changes that have been implemented during the COVID-19 pandemic might disproportionately affect people with chronic pain. And the reason is because we know that people with chronic pain already face these social threats because of the chronic pain that they experience. And what we saw was these very striking similarities between the social threats that we identified for people with chronic pain and the social changes that were implemented during the pandemic. At this point, I would like to give a special shout out to the social aspects of pain special interest group of IASP. This group is devoted to better understanding the social dynamics of pain. And I've highlighted here a small subset of the people of this special interest group who were directly involved in the project that I'm going to talk about right now. So what we did is we tried to identify certain social challenges that are a direct result of the changes due to the COVID-19 pandemic that might detrimentally and disproportionately affect people with chronic pain. The first one is a rather obvious one, which is social disconnection. Social distancing measures specifically had the goal to keep people at home and away from one another, and are very likely associated with increases in social isolation and disconnection. The second one, that's a bit the flip side of the first one, is that people were forced to stay at home. It meant that they were also often forced to stay with other people at home. It might be their family, it might be a partner, it might be the combination of work from home with family life. And this can be of help. It can mean more increased social support, but it also means that all the stressors from the situation were shared in a very enclosed environment with a few number of people. There was very little room for your own space in isolation from others. And this has certain risks as well, which I will talk about in a second. The third one is healthcare. Healthcare has specifically received attention because what happened is that the priority of pain management has been reduced in order to deal with the COVID-19 pandemic. COVID-19, of course, received primary importance, and that meant that pain management specifically was put on the back burner. It also meant that certain healthcare and pain management strategies were harder to implement. So for instance, people with chronic pain could not see a physical therapist in person anymore, or a psychologist, for instance, and they had to rely on other forms of pain management. So access was actually made more difficult during the pandemic than it was before. We also know, and that's the problem, that pain management already faced certain challenges. A lot of patients with chronic pain report still their pain is often unrecognized, undertreated, and that pain management is lackluster. So the pandemic likely made this even worse. The last point is social injustices and inequalities. We know that people with marginalized conditions who are marginalized by society already face an increased risk for the development of chronic pain. We also know that natural and societal disasters like this pandemic disproportionately affect people who are disadvantaged. That might be because of their skin color, their socioeconomic status. So these two things combined likely increase the risk for people with chronic pain who are already at a vulnerable position being disproportionately affected by the pandemic. Also, a pandemic, there are several studies showing that probably this gap between advantaged and disadvantaged is further increased in the time of crisis. So what we reasoned is that there is a likely an increase in the social threats that people with chronic pain experienced or will experience, and that these social threats based on the literature will likely precipitate, maintain, and exacerbate pain. So there's a real risk that during the pandemic, a lot of the social changes led to increases in social threats, and that has likely detrimental consequences for pain. At the time of writing, this was in the early months of 2020, so last year, there was very little data. So what I wanted to do is to, in addition to this, also discuss a little bit the support for the different areas that we identified, starting with social disconnection. There is indeed a lot of evidence now that social isolation and loneliness increased during the pandemic. Social distancing measures had an effect with people sitting for prolonged periods of time at home. And of course, they still had virtual ways of gathering, but it increased social isolation and loneliness on the whole. We also know, and this is from a nice study being done in Japan with 25,000 participants, that this perceived isolation or the perceived isolation was related to increases in pain severity and chronic pain prevalence. So there is a direct link between an increase in pain and perceived social isolation. This is of course problematic because this is a global problem. The study was done in Japan, but it is very likely this was also perceived in all the other countries where social distancing measures were put into place, which is most countries. The second one is proximity. What I mean here is that the quality of the relationships that you had with the people that you were, for instance, living with might also have, of course, an effect on your health. So, for instance, there is studies showing now that the aggravation of pain for some people was related to their relationship quality. So if you already had a poor relationship with, for instance, your partner and you were forced to stay at home a lot, this might have led to aggravation of pain. And there are several mechanisms that would be likely to explain this, like for instance, if there's already bad coping strategies between partners or low social support, a lot of stress, then this was likely worse if during a time of increased stress during the pandemic. Secondly, there is the perception of increased dependence on others. So in the time of the pandemic, there was especially a need for help of others because there was increased depression, increased stress, increased anxiety, which might all make pain worse. And especially in the time of social distancing, people had especially need for the help and support of others. Again, this need for increased dependence or the feeling of increased dependence on others was also related to increased stress and pain, especially because people feel that they are a burden on others. So increased dependence on others was also related to more pain. Lastly, and this is a very worrisome trend during the pandemic, is the increased prevalence of physical, child, and intimate partner violence. Again, this is not a surprise if people are forced to stay at home with someone who has maybe already before or after had a tendency for physical or psychological abuse. This was likely increased during the pandemic because of stress and more opportunity because of the proximity. And there is a lot of research showing that physical abuse is related to chronic pain. It can lead to increased prevalence of chronic pain or make existing chronic pain conditions worse. As of yet, I am not aware of any studies that looked at the relationship between this increase in physical abuse during the pandemic and pain, but it is very likely that there is a relationship. Lastly, not lastly, second to last, healthcare. With healthcare, we know that there is overall reduced access to healthcare. people are not as likely, we're not able to see their therapists anymore, physical therapists, psychologists, especially multidimensional, multidisciplinary pain management treatments have suffered. There was a general shift from physical and psychological treatments to pharmacological treatments, which is likely because pharmacological treatments do not rely on physical proximity. And this is, of course, a worrisome trend. We know that there's great promise to treat pain from a multidisciplinary standpoint because of biopsychosocial dynamics. And a general shift to pharmacological treatments only is worrisome, knowing, for instance, the effect of opioids. The second thing is that there has been a shift to more virtual treatments, but at the moment, the empirical basis for these treatments is lackluster. There's now a big move and a big push to invest more forcefully into these virtual treatments and telehealth, but this is still in the beginning phases. So in general, there was less attention for pain management, good quality pain management during the pandemic. There was also perception of reduced importance of pain management. As I said, the importance was clearly placed upon reducing symptomatology of COVID-19. Resources were invested into that. So treatment of pain, especially in the context of chronic pain, was lost further on importance. And this is also, of course, a perception that was already pre-existing with people with chronic pain. And it places also into the perception of their pain not being taken seriously, which we also know impacts upon pain itself. Lastly, then, social inequality. Valerie will talk more about this, so I'll keep this rather brief in the last talk, but there is indeed evidence now that increases in pain were related to, and this is cross-sectional and longitudinal research, increases in pain were related to several marginalized populations, so for instance, based on your race, disability status, low education, lower socioeconomic status. These might all impact upon your pain, and this was especially pronounced during times of the pandemic, which put especially stress on people who are marginalized socially to begin with. Also, this is a worrisome trend in general, not just with pain, but social inequality is very directly related to health inequality. That means that people who are socially disadvantaged are also often disadvantaged for appropriate healthcare treatment. And this is especially pronounced during the pandemic. For instance, if you're asked to work from home and this is not really a possibility because of your financial situation, this places a much bigger burden on you and also health-wise than with people who are easily able to work from home. Also, sanitation is another one that is much more common in higher socioeconomic status and is harder to attain in lower socioeconomic status, again, increasing the risk for poor health outcomes. In general, the pandemic likely increased the social disparities that were there to begin with that already affected pain treatment based on several factors. And it's again a worrisome trend that likely places a bigger burden on people with chronic pain. This graph summarizes some of the things that I had just talked about. On the top, the 4 pillars that we see as risks, as social threats for people with chronic pain. At C, you see some more specific outcomes of these changes, like for instance, perceived invalidation, like I talked about, solicitousness or sickness reinforcing behaviors by others that you're forced to spend time with, interpersonal conflict, which we know has increased, and an increased stress from child and family care burdens. Taken together, we believe that there is a real risk that these social changes led to either the development, maintenance, or exacerbation of chronic pain. And there's only a few factors that we know of that haven't received a lot of attention yet that might buffer against these effects. Introspection and increased self-care, virtual support and telehealth interventions, like I mentioned, and certain changes in social policy to address some of the social inequalities, like for instance, government-funded help. So taken together, there's a real risk of people with chronic pain being left behind. There's a real risk that chronic pain is a problem that has been disproportionately affected by the pandemic. And like we said, to end on, we believe that it's really important to do further research in this area, because the pandemic has shown that it is really relevant for pain and health in general. First of all, social consequences. We don't know a lot about the social consequences of the pandemic yet. There's more research coming on, but we need more longitudinal studies to evaluate the impact of the pandemic, especially on people with chronic pain. Underlying mechanisms, this is another one that we don't know enough about. This requires fundamental research, looking into biopsychosocial dynamics and how social factors can actually impact upon pain and vice versa. Digital social support, we know that social support is a buffering, can have a buffering effect for people with chronic pain, but we don't know much about moving this to the digital domain. This is something that has been made clear during the pandemic. But we need more research to understand if digital social support might be another avenue to buffer against, for instance, social isolation. Similarly, digital pain management hasn't received enough attention yet. Digital pain management has a great promise to make pain management offerings place independent. It might increase the access that people might get to pain management, but there is not enough clinical trials yet to really speak onto the effectiveness of digital pain management interventions. Resilience, related to what I talked about before, we need more research into inter and intrapersonal resilience factors. Social support might be one, but there's other factors that might buffer against the effects of social threat for people with chronic pain that we don't know enough about. And lastly, and this is a very important one, social determinants of health become increasingly important, increasingly recognized as one of the most important factors that determine health in general and pain in particular. And we need more systematic research to evaluate changes in policies on a global, international level to see how we can address existing social inequalities to better protect people who have been disadvantaged by, for instance, socioeconomic status. And with that, I would like to end on the following note. The pandemic has definitely put a spotlight on social determinants of health. It has led to very striking social changes, which likely will have an effect for years to come. But it also offers an opportunity. And this is an opportunity to better assess, mitigate, and prevent forms of social threat for people with chronic pain, to recognize that these changes have an impact, and to think about actively and research how we can address these social threats and these sources, not only during times of the pandemic, but also when the pandemic is over. And with that, I would like to thank you for your attention. And if you have any questions, please feel free to ask.
Hi, everyone. Thank you for joining this session. I'm very excited to be joined by my amazing colleagues, and some of whom are collaborators today. So I'm really excited to pivot from what Kai just shared with us and really focus on pediatric chronic pain, and particularly the impact of the COVID-19 pandemic on youth with chronic pain and their families, and what we're doing to really drive forward initiatives to give early, rapid access to virtual care solutions. Before I start, I have to say that I am the messenger. I am a co-principal investigator on this line of research with two incredible friends and colleagues who have really spearheaded this work. So Dr. Jennifer Stinson, who is at the University of Toronto at the Hospital for Sick Children, and also Dr. Katie Burney, who's at the University of Calgary and Alberta Children's Hospital. And they have so generously shared their slides, and I really want to represent them well today. So pain and mental health, particularly in youth, was considered a health emergency even before the pandemic. And we know now that because of the uncertainty, the restrictions, the financial strain, all of what the COVID-19 pandemic has brought, which is extremely a prolonged stressor, we know that pain and mental health, particularly in vulnerable youth, are poised to reach almost catastrophic rates. So we need to understand who's at risk and why. So at the beginning, in the first wave of the pandemic, Dr. Stinson and Bernie and I surveyed almost 300 youth with chronic pain, about 230 parents and 244 siblings. And so this is a cross-sectional examination that happened beginning in July. And it's important to understand that about over half of these kids had been seen in a tertiary level pain clinic, but many of them haven't. So they were recruited from the community. And while this is a one shot, snapshot of what's going on, you can see here that there is cause for concern. So 60% of youth reported that their pain had gotten worse during the pandemic. 40% were reporting moderate to severe pain levels of pain intensity. And if we look at clinical elevation, so that is whether or not they're a standard deviation above the mean and they're meeting diagnostic criteria for problems, you can see that 43% are clinically elevated for pain interference and 35% clinically elevated for anxiety and PTSD. 30% for insomnia. And I will say that this is much higher than the rates that we typically see prior to the pandemic. So a reason to be concerned. Over half of the kids are saying that they would meet criteria for a possible major depressive episode, and almost 30% reported using drugs and alcohol in the past year. But the healthcare utilization stats really we found staggering. So about a half of youth had reported that they'd seen their primary care provider for their pain problem in the last 2 weeks, and about 1 in 10 had been to an emergency department for their pain. So while this is a snapshot, it's a reason to be concerned because these rates are much higher than what we see prior to the pandemic. But we do need longitudinal research, right? And so the first study that actually came out, it was just published in Pain by Emily Law, Tanya Palermo, and colleagues, was a fantastic study of about 250 youth with chronic pain, predominantly headache, and they were assessed at 4 time points during the pandemic. And what they found was that symptom trajectories for pain, insomnia, depression, and anxiety, while they remained stable and in many cases improved, they were still persistent and clinically elevated, particularly for mental health symptoms. And they found that the effects of the pandemic were not uniform across all kids and families. So those families who had experienced secondary economic stress, those were the kids that were reporting increases in pain interference, and parents who were reporting a worsening of insomnia, really highlighting, I think, what Kai really nicely illuminated around the importance of disparities in this pandemic, and particularly for pain and mental health. And so these authors really called for the importance of not delaying assessment and treatment and really looking to distance means for ensuring that this happens. So we also were interested in longitudinally understanding whose pain and mental health is getting worse over time and who's getting better. And so we had access to a cohort of youth with chronic pain who were assessed prior to the pandemic, and we followed them and their parents up during the first wave of the pandemic. So this is a smaller sample of 84 youth and 90 parents. And basically, not surprisingly, what we found was parents and kids who were doing worse prior to the pandemic were doing worse during the pandemic. However, if you look overall, youth were actually reporting decreases in anxiety and pain interference, and parents were showing worsening of depression. But again, like Law and colleagues, the effect of the pandemic was not uniform. So those families that had experienced greater personal impact, that is, they've had direct COVID exposures, someone they know had died or had tested positive for COVID, there had been financial and social strain, those families showed a worsening of youth pain interference and anxiety, and a worsening of parent anxiety, again, highlighting the importance of personal impact during this time. But we were also interested in whether or not parents and kids' individual personality traits might buffer against risk or exacerbate risk. Because many kids were telling us, oh, I'm extroverted, so this pandemic is really hard for me, or I'm introverted, so it's easier for me. The restrictions are easier. And so we wanted to look at this because if we look to the natural disaster literature, for example, Hurricane Sandy, which happened in the United States several years ago, it was found that parents and kids who were higher in neuroticism and lower in extroversion showed a worsening of mental health over time. So we wanted to see if that was the case during this prolonged stressor that is the COVID-19 pandemic. And we were also interested in conscientiousness. So that's your tendency to be organized, detail-oriented, and self-disciplined. So we thought this might be really relevant during the pandemic because, people higher in conscientiousness may be better able to adhere to public health restrictions, cope better with them, and therefore have a greater sense of control and well-being. And you can see here that personality really mattered. So for kids, those kids who were more personally impacted by the pandemic showed a worsening of their anxiety over time, but only for those kids who were low in conscientiousness. Similarly, for parents, those who were more personally impacted by the pandemic showed a worsening of their anxiety, but only if they were high in neuroticism and low in conscientiousness or extroversion. So this is really, I think, interesting because it's showing, again, like Law and colleagues showed, that the impact of the COVID-19 pandemic on pain and mental health in these families is not uniform, but it's not just the impact of the pandemic, it's what we come into the pandemic with in terms of our individual personality styles. Now, my amazing PhD student, Alex Neville, did a really in-depth, deep dive qualitative analysis, and this is in partnership with Abby Jordan at the University of Bath, with 20 parent-child dyads. So these were hour and a half long interviews with parents and kids separately, and she applied reflexive thematic analysis to understand further and more deeply what the impact of the pandemic was. So there were 4 themes. The first that was really clear and is echoed from Emily's work is really this impact on mental health. So many of the kids and parents were saying, our pain is fine, but we're seeing these increase in anxiety. Many of the, there was one father we interviewed who, cried throughout the entire interview. And we have to understand that it's not just been the COVID-19 pandemic, but the other events that have happened in the pandemic, including economic recession, the George Floyd murder, et cetera. And so families were really grappling with this, and particularly parents talked about the impact on their mental health. They also talked about how this was intricately tied to their pain, right? So what they were seeing was a increased exacerbation in their mental health, which was then influencing their pain experience. Secondly, they talked about coping with pain amidst the pandemic restrictions and how the pandemic had really altered their previous styles of coping. So for example, Amelia here was talking about how distraction had been previously really helpful for her, but without school, without social outlets, she wasn't able to really engage in those previously effective coping strategies to manage her pain. And interestingly, as you can see from Jasmine's mother here, and we hear this time and time again, families were telling us, well, I'm really extroverted, or she's really extroverted, so it's been really hard on her. That's interesting for me because that does not mirror what we found in our quantitative analysis. Thirdly, this was experienced as a significant stunting or interruption in normal adolescent development. So you can see from Victoria's mother here, she's talking about how her daughter had really made great strides in getting through high school and engaging in life and really thinking about her imagined future. And, many of the kids talked about how the pandemic had really put all that on hold and had really stunted that. Whereas other teens would talk about how this was actually accelerating their growth. And this is really mirrored by the work of Abby Jordan and colleagues who have talked about the impact of chronic pain on adolescent social development. And this was sort of doubly impacted during the pandemic. And finally, as voiced by Kai, everyone talked about the impact on their care. And while many families talked about how this pivot to virtual care was a positive thing, there were also families that didn't feel positive about it. So Adam's mother here talked about how shifting from in-person care to online care or telehealth was super unrealistic. And Naomi's mother here is talking about how, many of these families, while they have chronic pain and a chronic illness, they felt extra vulnerable in the face of this virus. And so many of them avoided going to the hospital for when in-person care was an option for fears of contracting the virus. So this paper now is under minor revision, and we're hoping will be published soon. I'm happy to share further with anyone who's interested. So what do we do about this? We know that certain families are really at risk, and I will couch this in saying that a lot of these findings were from the first and second wave and the third wave of the pandemic. So what is the impact on pain and mental health now that we're in the fourth wave and potentially a fifth wave, And so I think we can't wait. It's great to show that this is having an impact, but we need to do something about it now. And we know that many children who suffer from chronic pain, and we're seeing in our, from our European colleagues that we are seeing new onset pain complaints during the pandemic. And we need to do something about chronic pain now before it can really mushroom into other issues like mental health problems and a lifelong course. So we know that virtual care is needed now. It's a necessity, and it can really serve to really reduce disparities. We also believe in adopting a stepped care model to care. What stepped care is essentially, it's a resilience-based approach that provides rapid access to the least intensive intervention that's tailored to the person's needs, preferences, and readiness for change. And so this model is self-corrective, and care can be stepped up or down depending on the needs of individuals. And so what happens in stepped care is there's continuous outcome monitoring, so individuals can know how intensive or how least intensive to go. So an example here is really at the step one would be low level intensity interventions like apps and websites. Step two might be peer support. Step three might be minimal healthcare professional involvement, going up and up to more tertiary level care. And what we love about this model is it addresses intervention up to a tertiary care need, but it also addresses lower level interventions that can really be facilitate preventative approaches for new onset or early onset chronic pain. So all of this work is really in partnership with people with lived experience. And I'm really proud in Canada that this is a real movement that's taken off, and no one's getting off this train. And it's really intensified, and informed the questions that we ask, and I think the impact of the work. So this quote is from Isabel Jordan, who's a parent of a youth with chronic pain who's on our research team, really talking about how challenging the COVID-19 pandemic has been, and the need for other forms of intervention now. So Isabel said, the COVID-19 pandemic has brought an abrupt halt to our usual access to care. Virtual care has been an option for some, but for her family, it hasn't been a smooth transition. We need to understand what's out there and how we can use it so that our kids can still access pain care, even when their world has been turned upside down. So led by incredible Dr. Katie Burney, within 1 year, her and the team had synthesized the literature and beyond to really summarize what are considered the best practices in virtual care solutions for pain and mental health for youth with chronic pain. I don't have time to go into these now, but I will say that this paper will be open access in Pain Reports, and it really summarizes how we can leverage virtual care to provide better access, how we should implement it so it's freely available, ensures equity, it's developmentally appropriate, and it meets ethical standards of care. She discusses what the best platforms for virtual care are, and really what the identified gaps are to push this area forward. So I encourage you to check this out. And I think this work is important because the families who are telling us that this is unrealistic and isn't working, well, maybe if we use best practices, we can get more acceptability of these resources. What Katie also led was a really innovative methodology of systematic review to review not just the peer-reviewed literature, but also what was available in terms of resources and interventions through the literature, through app stores, and a broad call for innovation so that we could capture what virtual care solutions for chronic pain in youth existed that might be in the pipeline, that are up and coming, that wouldn't be found by traditional means. And what she did through this systematic review was generate what we call an evidence and gap map. And I encourage you to go to her Partnering for Pain website to look at this interactive map. What it does is it synthesizes, it organizes the resources that are out there, both by the level of stepped care from low intensity to high intensity, but also the type of intervention, the type of population targeted, and the type of technology required. So this is really great as well because it shows us what has low to high degrees of evidence as well. So you can organize the results by that. And it's really a one-stop shop to show us right now what's out there and what can be used by families. Jen and Katie have also led some really important work to ensure that these best practices are relevant to marginalized populations. So they have conducted focus groups and roundtables with both Black, Indigenous, and medically complex youth with pain, their parents, as well as clinicians and providers, as well as policymakers, to really understand unique considerations of implementing virtual care for chronic pain in these populations, and really proud to be a co-investigator on that important work. Finally, I want to talk about work that's led by Dr. Jen Stinson, and I'm happy to be a co-PI on this work with Dr. Katie Burney, where we're really looking to build a freely accessible, widely available pain portal that kids with chronic pain in Canada, and hopefully eventually beyond, can access to really access these interventions and resources along the stepped care continuum. And I'm really proud that this work has been in close collaboration with an amazing advisory group of youth with chronic pain to really understand what this platform should look like, how it should feel. And this is embedded within the Wellness Together Canada infrastructure. So this was developed during the COVID-19 pandemic to offer virtual mental health care along the stepped care continuum because it was really emerging as an important need within Canada. And so this is a pain portal within that infrastructure that youth can access. So we're looking at whether it's acceptable, how satisfied end users are. And we have several grants now, also in collaboration with Dr. Tanya Palermo, to examine both the implementation outcomes, but also the clinical effectiveness, not just in wait lists in tertiary care. But what I'm really excited about is that we're examining this among populations that might never end up in tertiary care, like those in the community or with first onset chronic pain complaints in primary care, which would increase equity and inclusion. This is our amazing Kids Pain Portal Youth Advisory Committee. I have met with these individuals. They are brilliant. It's a diverse group of kids and emerging adults who have a variety of pain complaints. And they have been involved from the inception in this project to really, help design our logo, to really shape how this portal will look and feel. And what the portal essentially is it right now provides at level 1 of the stepped care continuum educational resources. At level 2, it offers access to 2 evidence-based cognitive behavior therapy interventions. One is WebMap that was developed by Tanya Palermo, and one is I Can Cope that's developed by Jen Stinson, that have been shown to really be effective in reducing pain and pain disability. So that's at level 2. And at level 3 of the stepped care continuum is peer navigation, where peers who have chronic pain can actually mentor users in navigating and using this portal. So I'm just going to end by showing a couple of screenshots. We're really excited about this. This is where youth would log in. Again, anyone can access this in Canada right now, hopefully later beyond. So 12 to 18, they get started here. They create an account. They sign up for this Power Over Pain program. And what's really cool is that at the beginning, they fill out a baseline assessment to look at their pain and mental health. And every 2 weeks, they have brief assessments of their pain and mental health. So if they're showing a worsening of pain and mental health, they can be linked to other resources or move up or down the stepped care continuum. So in summary, it's clear that virtual care is essential right now. We need to address this pressing need from taking a toll on families. And we really believe that virtual care, if done in a best practice way, can not only provide widely accessible care, but it can be leveraged to really reduce inequities that we see when care is narrowed to just tertiary clinics. So in closing, I just want to thank this incredible, enormous team and also our funding agencies and partners. And I just encourage anyone who's interested in my work, please check out the Peak Research Lab website. Thank you for listening.
Hey there, and welcome to my talk. My name is Valerie Furushak, and I'll be speaking today about the impact of social distancing on chronic pain patients during COVID-19. I completed this work during my postdoctoral fellowship at Brigham and Women's Hospital in the Department of Anesthesiology, Perioperative, and Pain Medicine under the mentorship of Dr. Kristen Schreiber. So I'm pleased to share that we published this article in Pain. If you're interested in a more in-depth review, you're welcome to consult with the literature. So pain is modulated not only by sensory, emotional, and cognitive components, but also by social factors, including social connections. So despite the importance of social factors in shaping pain experience, social modulation of pain remains relatively understudied. And unfortunately, the COVID-19 pandemic has imposed significant changes in our social conditioning of the majority of individuals worldwide, including persons with chronic pain. So previous research has suggested that social isolation can result in adverse health outcomes in general, including worsening of mental and physical health, and can be associated with increased likelihood of emergency department admissions and greater length of hospital stays. Social interactions may also play an important role in modulating pain and the ability to cope in chronic pain. Thus, individuals with chronic pain are maybe at an increased risk of both physical and mental health deterioration during social distancing. So worsening of pain may contribute to a reliance on maladaptive coping strategies such as substance abuse and suicidal ideation. The aim of our study was to make the use of natural social experiment that COVID-19 pandemic has imposed to investigate social modulation of pain, specifically measuring the impact of social isolation has on chronic pain conditions. And we hypothesized that current pain severity and interference would be greater while under conditions of increased social isolation. So in terms of our methods, the study was a cross-sectional survey design, and we examined the impact of social distancing on pain severity and interference among chronic pain patients. So our eligibility was chronic pain, that of 3 months or longer, from surgical or non-surgical sources, as well as English speaking and 18 years or older, and also residents of Massachusetts. And we were specifically looking at Massachusetts just because social distancing fluctuated quite a lot between the different states as well as countries across the world. In terms of our study measures, we looked at pain using the BPI as well as pain catastrophizing scale and pain isolation questions. We also looked at isolation using the UCLA loneliness scale, the version 3, and then also adapted some social distancing questions as well. With mental health, we looked at the PROMIS depression, anxiety, and sleep disturbance, as well as we looked at distress tolerance scale and the primary care post-traumatic stress disorder for PTSD version 5. For substance use, we use prescription opiate medication index, as well as tobacco and prescription medications and other substances from NIDA. And then we utilized univariate and multivariate linear regression to analyze and to assess the association of patient characteristics with the worst pain outcomes under social conditions. So in terms of our results, looking at the diagram of when the data was collected. So initially, we had in Massachusetts our stay-at-home advisory that was issued in March 15th. In terms of when we had ordered issues around masks and coverings in public situations was around April 26th. If you look at the green data marks there, that is the bulk of where our data was collected. So you can see it was right as social distancing occurred, and then we completed our data collection right around the start of phase 2 of when Massachusetts was planning its reopening. So kind of in the prime stages. In terms of our study flowcharts, the majority of our clients came essentially from Raleigh, which is just a research portal that Brigham and Women's Hospital utilized, as well as patients that were contacted from previous studies. Our final N was 150, and our primary reasons for ineligible screens were either no chronic pain, not current Massachusetts residents, or in one case, someone was under the age of 18. So if you look at our results, the participants had a mean age of 40.6 years old, 83% were female, and also in terms of 84.5% were white. So as you can see, there's a relatively biased stance within our data. Education was also 82.6% of participants had a bachelor's degree or higher. Employment was at 60.1%, which are full-time. In terms of looking at the economic stimulus check, there was 72% have received that as well. And of the people within that timeline, there was 18% that were tested for COVID and only one positive screen. So in terms of what the pain conditions were, 57.3% reported back pain, 25.3% was fibro, as well as 11.3% persistent post-surgical pain, and then 58.7% was all other pain. Then a minority of the patients that had completed this survey, there was only 12.7% that were currently taking opiate medications. So comparing the current state to recalled state from before social distancing, most respondents reported a significant increase in both their physical and social isolation at the time of the survey completion. And on average, patients reported feeling 54% more physically isolated and 42% more socially isolated compared to before social distancing. So patients reported changes in their use of electronic means as well. And as you would anticipate, there were larger increases in video chats, phone calls, connections with social media, and then obviously less around in-person events as well. The patients endorsed the importance of treatment restrictions. So 70% agreed or strongly agreed, and decreased activity was 66.7%, either agreed or strongly agreed due to social distancing as an important reason for their pain actually worsening. So additionally, increased stress, which was 67.3% agreed or strongly agreed, and lower mood, which was 53.4% agreed or strongly agreed due to social distancing as well, was cited as the most important pain worsening as well. So interestingly, fewer participants actually cited loneliness as responsible for worsening their pain condition. So generally, participants reported decreased utilization of pain management services, and at the same time, they reported an overall increase of self-management techniques, which I would imagine would be largely hypothesized in the fact that they were no longer able to go in person during the social distancing closures. So in terms of looking at some of the analysis, you can see that there were numerous variables that were significant in our univariate analysis. My apologies for the busy slide here, but I'll speak to some more in depth. But recognizing that many of the variables are closely related, we also utilized a multivariate linear regression to examine factors that were independently associated with worsening pain outcomes during social distancing, including variables that were significantly associated with the outcome on the univariable regression analysis of either p-value 0.1 or. So if you look at our multivariate analysis, model 1 explained 43.3% of the variance in pain severity and revealed that female gender, non-white race, lower education and disability, employment status, fibromyalgia, and higher pain catastrophizing scores is independently associated with worsening pain severity. Similarly, model 2 explained 48.4% of the variance in pain interference and revealed only female gender and higher pain catastrophizing as significant independent predictors. So in terms of what does that mean? So throughout the COVID-19 pandemic, sociodemographic factors have played a fairly important role with inequities in case incident, morbidity, and mortality amongst minorities. And this pattern is expected to only worsen as we continue to move forward in the pandemic. COVID-19 has revealed broader disparities within our society, providing an opportunity to prioritize our strategic efforts to address the inequity, including basic needs and access to medical services and appropriate pain care. So despite that our sample had a relatively small number of minority participants, we still observed an association with greater pain severity, which suggests that it would be beneficial to develop more additional research and program targeting to rectify this inequity. So while we did find that anxiety, stress, depression, and sleep disturbances were all associated with worse pain under conditions of social isolation, pain catastrophizing was the only psychosocial variable that was actually independently predictive of worsening pain severity interference. So it may be possible that being physically and socially isolated may contribute to higher levels of catastrophic thinking, including feelings of helplessness, rumination, and magnification. So pain catastrophizing may represent an essential communicative function during socializing for chronic pain patients. Thus, it may potentially be that heightened pain expression by catastrophizing can serve as a useful purpose, allowing that the individual distress about pain to be recognized and managed within their social context. So pain catastrophizing may potentially serve as an adaptive function and maladaptive function as well, amplifying pain severity and disability in a process that has been consistent with their findings. Our study sample reported significant disruption to their lives, including restricted pain-related services and a need to rely on self-management techniques and remote online forms of communicative social support. So potentially the increase in global use of social media platforms to maintain connections while social distancing suggests that people are becoming more accustomed to and more open to utilizing these platforms when seeking support for their pain. So in terms of our limitations, obviously looking at the demographics, our participants are from an urban academic medical center in Massachusetts. So they were predominantly white, female, and higher formal education, which limits our ability to generalize, and study participants only had online access, which may not be represented as some of the high-risk patients. The study also was relatively small. It was also cross-sectional in nature. Future research should certainly look at utilizing a longitudinal design with larger samples for pre and post data. And excited right now, we're actually 1 year from this study, we're collecting the same data so that we certainly can do that now as well, which will be interesting. So in planning for the future of service delivery for chronic pain patients, it's imperative to develop a better understanding of the impact of social distancing amongst different types of pain patients in other geographic locations. that are impacted by COVID-19, and specifically allowing the identification of those for whom it's most problematic. So this information could be beneficial in helping to guide development of innovative approaches to support this vulnerable population in the case of potentially subsequent waves of COVID-19, where social distancing mandates may continue to be in effect, which we're observing currently. So just a big thank you to the team that was involved. As I mentioned, Dr. Kristen Schreiber was my primary mentor, as well as the funding came from her R35, as well as Bob Jameson, Rob Edwards, research assistant Michaela Flowers, and Desiree. Thank you very much, and certainly welcome any questions. I appreciate your attention to our work.
Hi, everyone. I'm Tanya Palermo. I'm in Seattle, Washington, at Seattle Children's Hospital and University of Washington, and it's such a pleasure to moderate this session today. Thank you so much for joining us, and to IASP for hosting this event. And we'll look forward to a few more days of programming around COVID-19 and pain. I want to thank Melanie and Kai and Valerie for the fabulous talks, and let folks know that you can send in questions to the chat right now and we can open up discussion. And I see some questions now, so we'll get started with those. So the first question is from a chronic pain PharmD, who I think this is directed toward Melanie about your sample in your study looking at the impact of COVID-19. Wondering if you noticed, especially for those close to age 18, if they needed medication for anxiety and chronic pain. So wondering about whether you measured or assessed medications and medication changes, and also whether patients were being followed by chronic pain specialty clinics or by primary care. And then in terms of measurements of pain, whether you measured pain intensity or pain interference, and what other characteristics you might have measured. So take it away, Melanie.
Okay, thank you for that question. So we did assess healthcare utilization. This data is fresh off the computer, so I will say it's not fully analyzed yet. In fact, we just got some of the findings on healthcare utilization from our statistician like a couple of days ago. So we focused on ED, emergency department visits and primary care visits, but there is some information on medication use. So we'd be able to analyze that. And I will say that's really important. Like I think seeing, I was very, we actually got this on Friday. I was surprised by the rates of mental health, clinical elevations in mental health, but it was the healthcare utilization that really, I think, really kind of made us pause. So we'll have to analyze that data. So I encourage you, if you want to DM me, direct message me, email me, we'd be happy to kind of run that data. And that will be in the paper that we're working on and we'll be submitting in the next month or two. So I will also say in the grants that we're collaboratively submitting, healthcare utilization is a key outcome to assess clinical effectiveness and changes over time. And so we will certainly be collecting information on prescription use. I will have to check though whether we're collecting that information on prescriptions for mental health issues, because I think what's been really clear from both Tanya and Emily's work and like our work is that, you know, we can't just focus on pain in this pain sample, that, you know, we know that pain and mental health are so comorbid. And what we seem to be hearing from families is that they're really noticing an impact on their mental health. Again, that a lot of our data was from the first wave. And we know from empirical research that if we're seeing exacerbations in mental health concerns, we will also see subsequent exacerbations in pain and pain interference. So thank you for that question, because we'll make sure that we include items on mental health prescriptions as well. In terms of the pain outcomes that we're prioritizing, it's What we're really focusing on is pain intensity, but even more importantly, from a treatment perspective, is pain interference and the degree to which pain is getting in the way of life. However, intensity is important because we're hoping with this stepped care model to really also target not just those individuals or those kids that have had pain for many years and it's been getting in the way of life, but maybe they're seeing like increases in new onset pains or newly chronic pains. So intensity is more of a primary issue than functioning right now. So those are the two outcomes that we're focusing on, and we're actually powering the study based on interference. And Tanya's trial, so WebMap is one of the CBT interventions. It's been really shown to be effective on the interference or the disability or the activity limitations caused by pain. So we really see that as primary, especially when pain is entrenched and chronic. What was the third aspect of that three-part question, Tanya? I think, did I leave?
Actually, I think you covered it.
Okay. Okay.
Can I expand on that a little bit though,
Yes,
about
please.
measures? I actually wanted to ask you and Kai both, in terms of just measuring COVID impact as well as social isolation, do you both have recommendations? I know that there's been measures that have been kind of quickly put together to measure especially COVID impact and exposure, but would love your thoughts just on how you felt like measures performed and what would be your recommendations.
Kai, do you want to start? And I'm happy to expand.
Probably you will be able to talk more about that because we haven't actually collected data regarding social impact on COVID. Ours was more of a theoretical paper trying to guide the research a little bit. And that was one of the big gaps. And I think that's especially in the social domain that there is a big gap in terms of measurements that can really capture social consequences that are important for pain. And I think that was one of the aims that we also put in the paper. There is several questionnaires looking at social isolation, loneliness, and they have also been used quite extensively with regard to other health concerns. But specifically for COVID, I'm not aware of so much, but Valerie would have probably been able to talk more about that because she actually she focused on social isolation. But from our perspective, that was one of the big gaps that, especially in the social domain, there's a lot more work done to validate and develop new questionnaires and surveys.
Yeah, so I remember it's amazing how much of this work has been done in just a year. Like I was talking to my colleagues, Katie and Jen, earlier saying like, it was a year ago we were writing this grant and feeling like we need to understand the impact. And so at that time, what we did, we actually have a colleague who did a lot of that Hurricane Sandy work. So when we were struck with this pandemic, we thought, what can we draw on? Like what, the last pandemic was before we were born, right? And so what we did was draw from the natural disaster literature and measures that have been used in that context, albeit it's different, right? Because if you think of a hurricane, while the effects can be long lasting, it's not this multi-wave, multi-hit, prolonged kind of stressor. So what we did is we adapted a measure that had been published in the Hurricane Sandy context and really expanded it to be appropriate for, or what we hoped would be appropriate for the pandemic, COVID-19 pandemic. And that our measure, like yours, Tanya, does assess financial secondary kind of economic stress. But it also assesses, again, how close you were to the virus. So was your parent, so we had a child and a parent measure. So in the Hurricane Sandy literature, there was only a parent measure. So we adapted a child measure. So when we asked parents about like the impact on their work, we asked kids about the impact on their school, whether they had to do remote schooling, how close they were to the virus. So were their parents frontline healthcare providers? Did anyone they know die or contract COVID? Were they tested, et cetera? But we also looked at this, Kai, I hope you're happy with this, the social context and the social impact of that on friendships and relationships. So our measure, again, it's all under review, so it's not, but I'm happy to share with anyone, hopefully we'll get it published soon, is really an kind of a multifaceted measure where there could be subscales, but we actually used a total score to look at social, academic, work, financial, impact. I will say it was a rush, right? And I'm so glad that many of us independently were thinking about personal impact, because clearly from your work, Tanya, but also ours, that was really critical in understanding, the pandemic, especially in the first wave. Many kids were saying, I feel great. I don't have to go to school. Like the pressure's off, and they actually saw an improvement in their pain and mental health. Now, whether that persists, we don't know, but really it was really that personal impact that drove whether or not the pandemic impacted them. So happy to share the measure that we had. And I know that and KZAC in the States had also created a measure that's freely available for use with pediatric populations as well.
Great, thanks, Melanie. So another question about whether you all have recommendations for young people in particular who have risk behaviors to avoid pain.
So just to clarify the question, so sort of kids who engage in risky behaviors, what would be the recommendations to avoid pain?
Perhaps talk about how managing pain might be different in young people who have risk behaviors. And I was thinking about, when I read this question, a lot of the general population studies that have been done during COVID showing increases, for example, in substance use, especially in young adults. And so I think maybe addressing other types of risk behaviors as well.
I feel like throwing it back to you, Tanya, because you're like way more published on that than me and have done some really cool work in your lab on like alcohol and drug use. I mean, I think some of the first papers in tertiary seeking kids with chronic pain. All I can say is that, almost 30% are saying 30% of these kids, half of which are tertiary level care seeking patients, and those from the community are saying like they're using drugs and alcohol, which we know is a risk factor for worsening pain and mental health. I don't mean to throw it back at you, but you're such a wealth of knowledge, and I bet you have thoughts on that.
Yeah, no problem. I was thinking about some data we have in our lab that Dr. Simon Tham collected that is based on a young adults cohort mostly in their early 20s, and does show that from pre to post-pandemic, there's an increase, especially in marijuana and alcohol use, which is consistent with what's been found in the general population. I think for some of our younger adolescents, we've actually found that having chronic pain can be protective against substance use, and because of the more limited social exposure that can occur in some of our younger adolescents. So I think it's sometimes a mixed scenario when we talk about what types of risk behaviors our patients with young patients with chronic pain demonstrate. Yeah, I think, I'm not sure in terms of recommendations if there's anything particularly different because of the pandemic or during the pandemic beyond how we would normally address those types of risk behaviors, except being sensitive to identifying changes that have happened over time. Kai, I don't know if you're familiar with anything from the adult world about just the connection between like social isolation and increases in risk behaviors, but also wanted to see if there's other connections that we should think about that have to do with the social context.
Yeah, actually, I'm quite surprised to hear that there's an increase in substance abuse among adolescents, because I know that from the literature, often one of the predicting factors is peer exposure, right? Like among peers, that is something that is more predictive of substance abuse. So it is, to me, a bit surprising that especially in social isolation, younger adolescents would have seen increase in those risk behaviors. And then I think the main question would be, where is that then coming from? If it's not from peers, for instance, what I could see is that, I think you're going to come back to psychological health and general well-being, that other predictors of risk factors is general anxiety, fear, stress, and especially maybe if you're stuck at home, if that's where the data is coming from, then I could also see that would be a predicting factor, and then you would again have to address, I think, general mental well-being in order to also address that. I don't know if focusing on the risk behaviors is necessarily the right approach, because I think probably the cause for the increase in risk behaviors and pain might be a third, like for instance, mental well-being, that would explain both, and that's what we should probably focus on.
Great, thank you. I'm not sure if we can expand a little bit on risk more to think about whether either of you have looked at data around suicidality and thinking about other kind of mental health risk, but thought I'd open that up too.
Yeah, it's in our sample, like the smaller, the sort of sample of 84 kids who we assessed prior to the pandemic and during the pandemic. You know, prior to the pandemic, we actually did a very in-depth clinical diagnostic interview called the Kitty Sats. And we focused on depression, anxiety, and PTSD, so internalizing issues that are really relevant. And actually, we are collaborating with someone in Halifax who's interested in suicidality in particular. So all I can say is we didn't repeat that during the pandemic, trying to keep this data collection feasible. Those clinical interviews can take hours and hours to do. So there are items on the depression questionnaire that get at suicidal ideation. So we could look at that sort of item level. But suicidality is definitely, it comes up. If you ask about it, it comes up. It's just sort of similar to trauma in the sense that it's a minority, but it's maybe a higher minority than we would expect or want. It would be fascinating to see if that has increased. But really, our assessment has been focused on sort of feasible, sort of brief questionnaires with clinical cutoffs. So I can't speak to suicidality in particular. You know, the issue that Kai talked about in terms of, and I mean, it's been talked about a lot in the news and the media around, you know, rates of ACEs and traumas during the pandemic. And so that is going to be really interesting to examine. And I will say that we did assess that in our cohort, although we haven't published on that yet, but that's data that we could look at to see if kids are endorsing a higher level of traumatic events during the pandemic, because that's certainly a concern for mental health providers in terms of sort of the isolation and being sort of stuck at home. And it was an issue before the pandemic, right? Again, in a minority, but it's something we really need to be attuned to. And all of this conversation just makes me think, you know, all of these things are so interwoven. So even if we don't see suicidality now, or, you know, increases in opioid use or, you know, cannabis use, if we're seeing an exacerbation, like Kai said, of mental health issues and then pain issues, we know through longitudinal research that those are risk factors for later substance use, right? So it's sort of like this chicken egg question where all of these things can really influence each other. How that happens temporally is a good question. And that's what I loved about your study with Emily, Tanya, is that sort of multi-wave approach to look at these symptoms and these issues over time. That's been rarely done empirically.
Yeah, I agree. I think it speaks to the need to have some longitudinal data to address what's happening over time, and it is lacking, you know, right now. I think some of us set up studies thinking the pandemic would end at some earlier point, and so we didn't anticipate that longer term follow-up would be important. It's interesting, here in Seattle, our inpatient psychiatry unit was full. They were unable to take kids who needed inpatient admissions because of really being overfilled for several months. So I know the demand was there. It's hard to know why, if it's just from the increase in mental health distress, or if it's because outpatient care dropped and access to normal mental health services wasn't occurring. But I know it was really a crisis for a time period. There were just no inpatient beds for kids for some period of time here.
Yeah, it's been some work by Sherry Madigan, who's here in Calgary. They had access to a really large birth cohort, so thousands of parents and kids, this community sample. And this was just published, I think, in the Lancet Psychiatry, but really showing a worsening of mental health over time, not just in the kids, but like we need to think about the parents, right? So like even in our studies, you had found an increase in, insomnia, particularly among those with financial economic stress. But overall, we're seeing a worsening in parent depression too, right? And so again, there may be lagged effects. We know that parent mental health is one of the biggest, most robust predictors of child pain and mental health. And so I think, more and more reason to kind of, get in there early and not just focus on the kid, but the parent too, because if we're seeing more issues and exacerbations there, we know from other research that we're going to see it in the kid.
Yeah, that's a really important point, Melanie. And I think we know, as you said, that parent functioning has such a huge impact on child functioning. And really, when we're talking about interventions and resources, it would be important to consider the family as a unit rather than just trying to target the individual child.
I'm actually curious. I don't know if I can insert a question or if there's still questions going on, but now that you're both talking about the effect on children, I know of studies that have looked at social isolation in people with chronic pain, but that were usually adults. And I'm wondering with children, they have this bidirectional effect. They're separated from their friends, their schools, but on the other hand, they are much closer to their family than they've probably always ever been before. And I wonder, do you have any studies that look into the kind of social isolation, especially in adolescence? Because there was a big debate here in Europe that this whole school, like in the forming years of adolescence, when you have your peers, your school experience, that is basically just ripped out. Sometimes adolescents even starting in a new school, and this whole or a study, for instance, if they're a bit later in life, and that has been really hard on them. But I haven't seen actually any hard data on experiences of social isolation and exclusion in adolescence and young adulthood and the effect on pain.
It's a great question. I don't know if there's data. I know from our qualitative interviews, which were focused on, in large part, on impact on school, in the study I did with Emily Law, we found that many youth perceived being at home as a very positive aspect of some of the consequences of the pandemic, because they did appreciate the time with family, they appreciated the flexibility and routine, and felt like it had positive impact on pain management. Of course, that's one group of individuals, and then another group who felt like it was terribly isolating and that it took away many pain management options that were effective, especially around getting out of the house, being active, and doing valued activities. So I think it's a mixed bag. I don't know, Melanie, if you have data in that space as well.
Yeah, I'm just thinking of it's really nice when independent research kind of corroborates. And so what you and Emily did find, we're seeing that too, not just quantitatively in terms of it's not uniform, right? Some kids are, closer to their family. They're it's like Abby Jordan's work, for some, this stressor has facilitated their development, has facilitated their growth, has, whereas for others, it's kind of really gone the opposite way. And so I'm just thinking of Alex's qualitative work that really kind of reflected that as well. So we're seeing that both quantitatively and qualitatively. I just Googled, just so I'd have a stat from Sherry's work. She did a meta-analysis of over 80,000 youth worldwide. It's in JAMA Pediatrics, and showed that 1 in 4 kids during the pandemic had elevated depression and anxiety. So I think this is why I'm really excited to sort of be partnering on this virtual care. Like, what are we going to do about it, kind of? And I think we're all coming together on this, because how many studies do we need to see? How much worse is it going to get through each wave? Social isolation is one factor, Kai, but I'm sure there are many other drivers of anxiety and mental health issues beyond. So I think we were really focused on social isolation during the first few waves. And in certain, and again, this is why we need our international colleagues, because it's not the same everywhere, right? Like if my colleagues in Australia, they have many lockdowns. Alberta will never have another one. So I think it's not just social isolation. I think regardless of where in the world, we're seeing a worsening, and why we're seeing a worsening of mental health, and we need to get on that. And from a pain perspective, if it's 1 in 4 that are showing elevations, we know what exacerbations and depression and anxiety can do, and trauma to pain. So we need to really shift to those amazing resources that are there and making them widely available.
Great. I think that's probably a good note for us to wrap up on. So wanted to thank Melanie and Kai for addressing all of these questions and stimulating discussion. Thank the audience again for your participation. And I hope everyone is able to join the remaining events being offered by ASP. But thank you very much.